Good evening and welcome to Conscience Incorporated, the convoluted history of religious hospitals and religious freedom in the United States, sponsored by the CPH Lecture Series. I'm Dr. Monica Perales, Associate Professor of History and Director of the Center for Public History at the University of Houston. Thank you so much for joining us for tonight's lecture and discussion. At CPH, our vision is to ignite an understanding of our diverse pasts by collaborating with and training historically minded students, practitioners, and the public through community-driven programming and scholarship. One of the ways that we do that is through this lecture series, which provides a unique opportunity for scholars, professionals, community leaders, and others to consider humanity's perspectives directly related to the decisions they make. Tonight's lecture is part of our year-long examination of the history of health, medicine, and healing in its many forms. Tonight's event and all of our CPH Lecture Series events will be recorded and posted to our website. To learn more about CPH, please visit us at uh.edu/class/CPH. We encourage you to add your questions to the chat box in the live stream at any time. These will be shared with our guest speaker in the Q&A portion of the event. This box is located on the right side of the streaming frame. Allow me now to introduce our moderator, Dr. James Schaefer. Dr. Schaefer is an associate professor in the Department of History. His research examines the social, political, and economic history of American medicine and healthcare. His first book, The Business of Private Medical Practice, explains the market forces that influence the office locations and career paths of doctors in early 20th century American cities. He's currently working on a second book that examines the practice of medicine during the First World War, both on the home front and overseas in American-based hospitals. The virtual floor is now yours, Dr. Schaefer.
Thank you so much, Professor Perales. It is my great pleasure to welcome Professor Ronit Stahl to the UH Center for Public History Lecture Series. Professor Stahl is an associate professor of history at the University of California, Berkeley. Her research centers on modern American history, exploring questions about pluralism in American society by, quote, examining how politics, law, and religion interact in spaces such as the military and medicine. Her first book, Enlisting Faith, how the military chaplaincy shaped religion and state in modern America, was published by Harvard University Press in 2017. Through the lens of the changing role and mission of military chaplains, the book explored the complicated intersection of religion and state, especially during wartime. Her current book project, quote, examines the rise of institutional and corporate rights of conscience in healthcare from the 1970s to the present. With that, I extend a warm welcome to Professor Stahl.
Thank you. I am delighted to be here today to join you, and I want to thank my hosts and the University of Houston and the Center for Public History for this opportunity to talk to you today. So I'm going to be talking about hospitals and conscience rights, and I guess I made a slight change to the title, or the subtitle anyways. I'm going to be thinking about Conscience Incorporated, the convoluted history of religious freedom and healthcare in the United States. And so what I'll do today is I'll sketch out a short history to help us think about the present. We're in a moment where religion and healthcare is in the news almost daily, whether it's about the pandemic or the provision of reproductive healthcare, questions around end-of-life care, or simply access to healthcare. So these are, I think, quite live questions. We live in a moment where there are hundreds of religious hospitals across the United States, and these religious hospitals are indeed corporations. And these corporations have legal rights of conscience as institutional actors, as organizational entities. And I want to use religious hospitals, therefore, to think about the huge and admittedly loaded question of the relationship between religious freedom and healthcare in the United States. And I want to be clear that this is a complicated, a complex, and challenging terrain to work in. It's a challenging present. It's also a challenging past. I realize that most, if not everyone listening today, will have their own views and opinions and normative ideas about what is right and correct in this realm of religion and healthcare. But what I want to do today is focus on the history. And in fact, the long history. When introduced, and this is totally fair because I haven't updated my bio on my institutional website, Dr. Schaefer talked about my book being about the 1970s to the present. And that is in fact where this project started. It's just that as I dug into this question of institutional or corporate conscience, I ended up going way back in time, at least to the late 19th century. And that's where I will take us today for at least a little bit. I want to note that there is often a lot of talk about individual rights of conscience, what an individual can either want to do or refuse to do based on a sense of conscience. This is a broad and deep philosophical terrain, a space of mass and important theological debate, and also a political tool that's used in public policy, in law, and in social and cultural spaces. But what I want to do is actually move away from the individual to think about the institution or the corporation, which again, all hospitals are in one way or another. Some are nonprofit, some are for-profit, but they all exist in a corporate form. Religious groups too, in the United States anyways, tend, for the most part, to have some sort of corporate form or corporate apparatus. And there's a long history of religion and corporations or the corporate form within religion. I'm not going to get into all of that today, but I just want to note there is a large and broad context for thinking about religion and corporations. What I do think is a little bit different about the realm of healthcare is this notion of corporate conscience. And this has long been debated. While we think about it today, often primarily in terms of reproductive healthcare and LGBTQ healthcare, and sometimes around end-of-life care, there were big debates around this notion of could a corporation have a conscience in the 1980s, as there were a series of cases about end-of-life care, and specifically whether hospitals needed to adhere to the requests made by patients to either get off a ventilator, to stop nutrition or hydration. And so this context of patients or their families on patients' behalf wanting to refuse life-sustaining treatment, and this question of whether hospitals had to listen to them, to accede to their wishes, whether if they weren't going to do it, they had to transfer care somewhere else, or they could just flat out refuse, led to debates in medical journals around this question of corporate conscience. So you get from George Annis, a bioethicist, lawyer, and professor, this question around what to do. And it's what he actually referred to as the ethical hot potato problem. What do you do when patients want something an entity, an institution doesn't want to provide? He rejected the entire premise of the hospital's legal claims, arguing that hospitals are corporations that have no natural personhood and hence are incapable of having either moral or ethical objections to actions. After all, he wrote, institutions don't practice medicine, only people do. So he wanted this to be, if you were going to deal with questions of conscience, it should be tied to patients and healthcare providers, not to the institutional form. But there were others who very vehemently disagreed. Many disputed his claim. So we get, for example, from Scott Helsper and Jeremiah McCarthy, a rebuttal arguing that the reality is that hospitals, especially religiously sponsored hospitals, may indeed be capable of having moral objections to treatment decisions. So it didn't need to be an objection from medicine as a profession, and it didn't need to be an objection from an individual doctor or nurse or any other clinician. It could come from the hospital itself. Again, this is hotly debated. It is still hotly debated. As a legal matter, however, Helsper and McCarthy were not wrong. As a matter of law, so again, I'm going to look at law here. You're welcome, of course, to have your own views on this, but as a matter of law, the right of an institution to conscientiously object to or religiously refuse to provide treatment in its facilities already existed. it already existed in the realm of reproductive health care, not at the time in the realm of all healthcare. And this goes back to 1973, which is, I admit, where I first thought this project would start. In 1973, in the United States, we get the first federal healthcare conscience clause, which is often referred to as the Church Amendment, named after Democratic Senator Frank Church. Because of time constraints, I'm not going to go into great depth about the Church Amendment as a policy or legislative history, though I'm happy to answer questions about it. But I do want to flag a couple of significant features about it. In public discussions then and now, and if you ever read anything about conscience and religious freedom in healthcare, if you read about a few years ago under the Trump administration, the creation of the Division of Conscience and Religious Freedom under the Department of Health and Human Services, the existence of the Church Amendment is often tied to the Supreme Court's decision to legalize abortion in Roe versus Wade. And I realize we're in a moment in which we just had a court case yesterday about abortion and Roe versus Wade. I realize we're in a moment where in Texas, where many of you are, abortion has been significantly constrained by Texas state law under SB 8. But I want to talk about the 1970s, and what I want to emphasize is that while the Church Amendment is not unconnected to Roe, the event driving it was not abortion, it was sterilization. And so what had happened was that in the fall of 1972, a woman named Gloria Taylor wanted a sterilization. She wanted a tubal ligation after a C-section, which is medically the smoothest way to do it. It's one surgery at once. Her doctor was happy to provide it. But she lived in Billings, Montana, where the Methodist hospital had recently merged with a Catholic hospital, and there was one hospital in Billings. There was only one labor and delivery unit in Billings, and it was at the Catholic hospital, which forbid sterilizations. And this, again, is about voluntary sterilizations. So Gloria Taylor did what many Americans do. She sued. And a Montana district court argued that the hospital had to allow the sterilization to proceed because it received government funding. It received government funding through construction funds and through Medicare and Medicaid. And thus, the district court argued that it was a state actor, that is the hospital, because it received funds, was a state actor, and therefore it couldn't use religious doctrine to refuse a medically accepted, a professionally accepted procedure. The bishops in Montana and in Idaho who were part of, were watching this closely, were furious, and they started lobbying Frank Church. In particular, they threatened civil disobedience, which is what he claims in the legislative history prompted him to act, because Catholic bishops were saying they were going to shut down hospitals. And in Idaho, for example, where Church was from, Catholic hospitals provided about half of the healthcare in the state. So he was saying he wanted a solution, and Church thought that he could come up with a solution that would kind of moderate the problem and contain it. So he figured, okay, we'll just give people some rights of conscience. They can receive federal funds, but still refuse certain procedures. So that's what the Church Amendment does. As drafted, it has several provisions. And the three key provisions are that, and this is all tied to federal funding, that federal funding does not require individuals to perform or assist in abortions and sterilizations. And again, the Church Amendment was about abortion and sterilization, not other procedures, if they invoked their religious beliefs or moral convictions. And I can talk more in Q&A about why we get religion and moral as distinct categories here. The Church Amendment also said that entities, that is institutions, did not have to make their facilities or personnel, that is their employees, their clinicians, available for abortion or sterilization. Again, if their prohibition is based on religious belief or moral conviction. And so again, there's this notion that institutions would have, as an institutional entity, an objection. And finally, that the receipt of federal funding does not permit employment discrimination in hiring, promotion, termination, or staff privileges. That is what enables doctors to practice in hospitals. Notably, this third provision is bidirectional, which is to say, you can't discriminate either because of willingness or refusal. And this has not really worked bidirectionally, even though the legislation theoretically protects both refusal and willingness. It has predominantly protected refusal, not willingness. Nevertheless, what you may pick up on here is some tension, right? Entities can refuse to make their facilities available. Individuals can object, but also supposedly people should be able to be what is often referred to as willing providers. And this relationship between individuals and institutions in the Church Amendment is focused on clinicians and hospitals. There's no really realm of patients here. This is really about the practice of medicine and in what spaces and structures it occurs. But this is the legal foundation, the statutory foundation for institutional conscience rights. It will expand dramatically. Church thought this would confine the problem. It does no such thing. It actually leads to a massive expansion at both the federal and state level of conscience clauses. And this notion that both individuals and institutions or corporations can object on religious or moral grounds to particular procedures. What you might also notice, and this is a paraphrasing from the language of the amendment, is that this is all hinged on federal funding. Because after all, a private entity that received no government money could do what it wanted. This is about the connection that the Montana judge ascertained between getting state or federal money and needing, therefore, to provide all care regardless of religious doctrine. So this raises a question that may seem kind of basic, but is actually a little bit tricky. Why are religious hospitals receiving government money anyways? Why, given the constitutional separation of church and state under the First Amendment, is money flowing from public coffers, which it does through things like Hilbert construction funds, Medicaid and Medicare, tax breaks? Why is it going from the government to religious hospitals? And this is a really complicated story that I'm going to sketch out through one particular hospital to illustrate how it is that religious hospitals get government money anyways. This is what takes us back to the 19th century. In 1861, the Sisters of Charity, a group of nuns, opened the first hospital in Washington, D.C. As the Civil War progressed and the number of wounded soldiers in the city increased, they quickly overran their space. They first started in kind of an old mansion. And in 1864, Congress incorporated Providence Hospital, and the Sisters of Charity then built a 250-bed institution, which was giant for the time. So it's a group of nuns, it's the Civil War, it's the Capitol, right? They are providing healthcare to soldiers in this space, and then to other people too. The mid and late 19th century was a time of enormous hospital growth nationwide, and especially significant religious hospital growth. Even new religions were getting into the business. Not more than a few years after its official founding, Seventh-day Adventists created their first sanitarium in 1866, which set the precedent for future investment in the American healthcare market. And so you get Baptists, Methodists, Adventists, Catholics, Episcopalians, Jews, the major groups in American life at the time, the major religious groups were all founding hospitals. Back in DC, Providence Hospital was, like all of these other religious hospitals, trying to provide healthcare to what it deemed good, upstanding members of the community, basically allowing middle-class, often immigrant Americans to access healthcare without needing to be either wealthy enough to afford a home visit from a doctor or so poor as to be connected to a city almshouse where a doctor might stop by. This again holds for Catholic, Protestant, and Jewish hospitals at the time. And Jewish hospitals arise in part because they're worried about Christian hospitals doing things like deathbed conversions. But they're also all kind of looking out for their working and middle class communities, but they are also treating other people. Scientific medicine was on the verge of rapid development, and it's a time where nurses were still providing much of the most effective care. And so in the case of Catholic hospitals, that was provided by nuns or the sisters who usually ran these institutions. Providence Hospital had an exceptionally good reputation for caring for sick and dying patients, not just during the Civil War, but thereafter. And this was true again across the city and the area, a good reputation amongst Protestants as well as Catholics. So unlike in the case of schools in the 19th century, Catholic hospitals were viewed as kind of good spaces that provided excellent healthcare. And they were Catholic institutions run by nuns, filled with shrines, statues, pictures of saints, fonts of holy water, and crucifixes. And that is from an architectural description of Providence Hospital at the time. It was to the nuns who ran it a religious space. In a tale familiar to many hospitals, it again soon ran out of space in its 250-bed building and needed more money for a larger facility. It was so bad that the Washington Post noted with alarm in 1886 that the wards originally set apart, and this is the language from the Washington Post, the wards originally set apart for colored patients exclusively are used by both white and colored, the same being the case in the female ward. That is, this had been a segregated space, segregated by race, segregated by gender, but there wasn't enough space for all of the patients who are crowding in. And so all of a sudden there's both race and gender mixing, which is quite alarming to many in the area and many at the hospital. So again, they're looking for more money. To raise money to expand, the hospital made 2 agreements with the government in 1897. First, it entered into a contract with the Army Surgeon General, such that for $250 per patient per year, it would tend to 6 Civil War veterans. And second, it made an agreement with the city commissioners, and keep in mind that Washington, D.C. is a federal city in 1897, that in exchange for $30,000 of construction funds, it would build a separate contagion ward for infectious patients. At the time, the infections of concern were cholera, smallpox, and yellow fever. So they build these new buildings based on these agreements, both for patient care and with these funds from the city. And so they're able to substantially expand, to remodel their space. This image here is of their new, even bigger, even grander hospital space. It filled up, as an article said at the time, an entire city square. So an entire block of Washington, D.C. And at the time it was located in Southeast near the US Capitol. But these agreements attracted the attention of one Joseph Bradfield, an angry, as he described himself, citizen and taxpayer of the United States and resident of the District of Columbia. He objected to city and thus federal money flowing to a religious hospital. And so he did what many good Americans do. He sued. His case, Bradfield versus Roberts, became the Supreme Court's first Establishment Clause case. Initially, though, before it gets to the Supreme Court, you'll notice a pattern here. The trial judge sided with Bradfield on the grounds that this collaboration between the city, between the federal government, and Providence Hospital created joint ownership between the government and a religious organization, and therefore it was a violation of the Establishment Clause. The government appealed, arguing that money alone did not create an establishment of religion. And I want to flag one thing here that's unusual about this case. The hospital isn't involved at all. It's a lawsuit between this angry citizen and the treasurer. Roberts was the treasurer of the United States. So Bradfield sued to try and stop the money. And interestingly, the hospital kind of sits back and lets things kind of play out. Bradfield was a Protestant. He was likely enmeshed in anti-Catholic politics of the day. And even on appeal, he kept arguing that these agreements violated the Establishment Clause by supporting religious societies and enabling, specifically, he said, a religious entity to carry into effect a public and civic duty. So he viewed healthcare as a public duty. So to give money to a religious group to provide that was, he said, a violation of the Constitution, and speedily obliterated, that's his words, the essential distinction between civil and religious functions. So what does the court do? The court, which is made up of 9 male Protestant justices at the time, issued a unanimous decision in 1899, and they rule in favor of the treasurer, which is therefore in favor of the government, which is therefore in favor of the hospital. And the opinion specified that even if Providence Hospital were a religious establishment, it certainly is not an establishment of religion. So it's distinguishing between the fact that an entity might be religious, but that doesn't make it government establishing religion. But even the court is actually a little bit dubious, if you read their opinion carefully, about whether this characterization of the hospital as a religious establishment makes any sense. So what do they say? In the majority opinion, and there's just one unanimous opinion, Justice Peckham, who tended to be wary of government regulation of business, deemed the religious identity of the hospital wholly immaterial, actually irrelevant, that it was incorporated as a Catholic institution. The opinion also argued that the influence of any particular church may be powerful, but it's surely not sufficient to convert such a corporation into a religious or sectarian body. That is because the hospital was incorporated separately from the church as its own separate corporation. It may well have been owned and managed by a combination of priests and nuns, but nope, it's fine. It is not a sectarian body. And finally, there's no allegation that the hospital only treats Catholics, right? It treats everyone. So therefore, the court provides 3 justifications for waving away the hospital's religious identity. The religious views of the management, according to the church, irrelevant, immaterial. Its purpose was healthcare, not religion, so its purpose was secular. The nuns actually probably would have disagreed that their purpose was secular, but they were never asked. And finally, the patient population, well, anyone can go into the hospital and access care, at least if you could pay for it. Now, it's not only Catholic hospitals that worked like this. The history of the Jewish Hospital of St. Louis also highlights how, although it was built with funds from the Jewish community, its mission and its pledge was that it would provide care and nursing to sick or disabled persons of any creed or nationality. So religion was not, for the most part, an obstacle to care, even in a religious hospital. In that sense, the court was correct. Hospitals did, at least in theory, treat whoever walked in their door, regardless of the patient's religion. And this is how we get to this conclusion, according to the Supreme Court in 1899, that a hospital called Providence Hospital, run by nuns, the Sisters of Charity, was simply a secular corporation being managed by people who just, happen to be Catholic. And so there's nothing sectarian about the corporation itself. So I want to emphasize here how quickly the court dismisses this institution as religious. And it's not just non-sectarian, it's suddenly secular too, right? So what had been a religious institution and was run as a religious organization and had nuns and shrines and lots of Catholic imagery was, according to the court, you could have walked over from the Capitol to the court to investigate, but that's not how Supreme Court arguments work. But it was, according to the Supreme Court, a secular, non-sectarian corporation. And in that sense, it became quite easy for religious hospitals to say they were secular, non-sectarian institutions. And by 1910, more than half of religious hospitals in the United States received government funding of some sort or another, according to the Commerce Department in a 1910 census. And this would have significant implications for the religious, but legally non-sectarian and secular hospital marketplace. In the case of Providence itself, it continued to grow. in part because of government money. In 1951, a federal appropriation to DC hospitals gave the hospital half of the $8 million needed for a new building. In 1956, the hospital moved from Southeast DC up north to an area right near Catholic University and into the larger building shown here. And again, you can see the nuns in habits of the 1950s and 60s standing in front of the sign saying, this is what we're building. And it's this 1899 case that led to this possibility that hospitals could get construction funds, grants, and later in the 1960s, Medicare and Medicaid funds. So this is happening across the country, not just in DC. And despite this, though, there aren't very many cases about it. There are actually only 3 across the 20th century. One involves the city of Ketchikan, Alaska, leasing its public hospital to an order of nuns for $1 a year to run it. And again, the court says, no problem. They don't see any religious influence in this space, so it's got to be secular. If you look at documents on the ground, the story is quite different. But from the court's perspective, they saw hospitals, because of this first case, as secular, non-sectarian institutions. Now, just because they were secular, non-sectarian institutions that received government money doesn't mean they weren't subject to the market forces affecting hospitals across the 20th and 21st century. And in 2017, Providence Hospital would shut down its obstetrics ward. And then in 2018, announced the hospital closure. And in part, the larger healthcare system of which it was a part basically said the population it serves is too poor and we don't have the money to continue to serve it. Even though, again, that initial case relied in part on being willing to serve whomever walked in the doors. Now we might ask, so what? Or the court said these places are secular, so what's so religious about religious hospitals? And the short answer is that it very much depends. Whether you would assess a hospital as secular, non-sectarian, or religious depends both on your perspective and the hospital itself. In the case of Catholic healthcare, by 1948, the Catholic Hospital Association creates the ethical and religious directives for Catholic hospitals, a document that will, over time, be the core principles according to which all Catholic hospitals have to operate. That was 1948 was the first edition. In 1971, the National Conference of Catholic Bishops starts to take over and determine what's acceptable. We're now in 2018, there's a 6th edition that sets out policies for Catholic healthcare institutions. So Catholic hospitals are one of the easier ones to identify where is religion in the hospital. Well, there's a document that says where and how religious doctrine affects care in the hospital. Just last week, there was a report out of Columbia Law School about Southern hospitals writ large, specifically Protestant and public hospitals focusing on reproductive health care, which highlights the ways in which religious restrictions on reproductive health care are not limited to Catholic hospitals. Another reason this is a very confusing landscape, both for people in the present and to study, is because it's not always easy to tell what a hospital is. So this is the case of the Jewish Hospital of Louisville, Kentucky, becoming part of Mercy Health, which is a Catholic healthcare system. And it's still called the Jewish Hospital, but it's part of Mercy Health. And it is, by virtue of contracts with Mercy Health, became subject to the ethical and religious directives for Catholic healthcare, even as it remained the Jewish hospital. And this is a phenomenon that legal scholar Liz Sepper, who's at UT Austin, has referred to as zombie religious institutions, that via contract law around sales, mergers, and acquisitions, even when, say, a secular for-profit entity buys religious institutions, there are also often restrictive covenants in sales contracts that, in the case of Catholic hospitals, for example, require a new secular for-profit hospital management company to continue to adhere to the ethical and religious directives of Catholic healthcare, even as it's no longer as a corporation, a Catholic corporation, but it is required to adhere to Catholic doctrine. It's messy, it's confusing, it's complicated. It's also complicated because it's not always clear what a healthcare system is. This is not always obvious. Sometimes it requires knowledge of religious language. Sometimes it depends on knowledge of a local area. Sometimes it depends on what you know about religious groups, or just in this case, these are all I pulled from Texas, some of which may seem obviously religious, Methodist, Baptist. But if you don't know that Baylor is a religious institution, or you don't know that Dell Children's Hospital is affiliated with Ascension, a Catholic healthcare system, and who knows what Texas Health Resources is if you just see the name and icon. So it can be quite confusing. And what's also not always obvious is that even if you know something's a religious hospital, it doesn't necessarily tell you what that means. What are the policies? What care can you get? How can you figure that out? And what is its conscience going to do to either provide or limit the care that one can receive in it? So I've sketched out a short history of how we get to this complicated place where it's not always clear what a religious hospital is, but we do know a few things. One, we know that there's a history of both the creation, the construction, and funding of religious hospitals with a mixture of public and private money. We know that in the realm of healthcare, there's an important role of institutions like hospitals, both providing care and helping set policy at the local, state, and federal levels. We know that there are questions around religion. Who is religious? What's non-sectarian? What's secular? What do these words mean? And what do they mean in practice? We know in the legal realm that there are claims about religious freedom within the realm of religion-state jurisprudence that transform entities from religious to secular spaces and that accord certain privileges to the voices of religious people. But this raises questions about politics and the power of institutions, of what religion is, of what counts as conscience, going back to the Church Amendment. What's a religious belief? What's a moral conviction? And what role, what power does the invocation of conscience have, especially at an institutional level, in setting the parameters and framework of how an institution, its clinicians, and its patients either work together or at odds? And finally, we can think about the public in multiple ways. What does the public know? What does the past public know? What do we know about how hospitals were understood in the past? What in the present can we figure out about what an entity is and what its history is? Again, if you're following these contracts, trying to figure out, well, what even is this? What do we know about it? And what does this tell us potentially about healthcare in the future and about this intersection of these huge and looming questions around religious freedom and healthcare? What can we learn from the institution of the hospital? What patterns or trends does it reveal? And what can we find out by looking closely at both what was intended and unintended about the way this history unfolds? So with that, I will conclude my speaking, but will happily take your questions.
Thank you so much, Professor Stahl. And I just want to remind the audience that we welcome your questions, which you can type in the chat window on the right of the screen where you're watching tonight's presentation. And it will make its way to us and we can answer it. But while we're waiting on some audience questions, I did want to get things going with a few questions for Professor Stahl. Thank you so much for that wonderful presentation. I learned a lot. I thought we could start off by addressing some questions that are related to public history and to some of the students that may be on the call, as well as members of the general public. So one question I wondered is if you could talk a little bit about the kinds of sources that you use in your research. I've used some hospital records for the late 19th and early 20th century, especially things like board minutes and annual reports and things like that. They're not exactly page turners, but I know that your work also must get into legal records and other things like that. So if you could say a few words about what kinds of sources you use and the challenges they present, but also opportunities.
Yeah, one of the biggest challenges in moving from working on the military to working on hospitals was figuring out the source question, because the military as a public government institution had a pretty clear source base where you go to the National Archives. Some stuff might be classified, but you kind of have some sense of what was there. Hospitals, as you know, are really, really different. And so it's been a blend of sources. Some saying these kind of hospital board minutes, records. One that's really also that I've learned healthcare institutions, even if you want records from like the 20th century, will often use current federal privacy law to try and restrict access to even institutional sources. Not all do, some are great, but it can be really hard. And some hospitals also, they'll let you see some stuff, but not others. So there's a lot of work to try and triangulate what you're seeing. So legal case records can be one way. And one thing I'm working on now, which is tricky, is, you know, the record for cases that are in the federal courts is a little bit easier to track and trace, but a lot of stuff happens at the local and state level. So trying to figure that out, because that then, you know, documents are entered in the record and you can move that way. It's also about using what kind of public material does exist. So, you know, there's a lot of self-promotional records. Annual reports, as you mentioned, are great. One thing that becomes clear in looking at some hospitals is the really different, I've thought a lot about the ways in which hospitals swivel and pivot about what they claim their identity is depending on their audience. So they'll say one thing in a courtroom and something very different in their annual report or in kind of brochures. And depending on the religious group, there is some, you know, really good material, for example, for the US Conference of Catholic Bishops and the National Catholic Welfare Council, or some of the other kind of sponsoring organizations. But again, they also, the records, especially as you get closer to the present, get harder in some ways to access.
Thank you. My next question will be a bridge to our first audience question. One of the places where you can find the self-image of hospitals expressed, especially in the 19th century, and even a bit earlier, is in rules for admission and discharge. And so when hospitals were under primarily lay control before the late 19th century, those rules for admission and discharge revealed a lot about what kind of moral image the hospital was trying to promote and what sorts of behavior they found acceptable and unacceptable. Has that proven useful, those kinds of admissions and discharge rules for you?
Yes, and even also, it's not just the rules, but the information they chose to collect. So, you know, you actually can get a lot of information from how people are described, right? What is their kind of occupation, or what does their family look like? Or, you know, at the same time, a lot of hospitals are claiming that don't worry, they're secular and non-sectarian. They're also very much tracking baptism records, you know, they're tracking sacraments or last rites. So, you know, you can actually discern, yeah, as you said, it's material that often seems kind of boring, but actually I think there are pretty incredible stories that you can pull out of it. You have to do a lot of work to really contextualize a lot of the numbers, but what I think is actually kind of fun about this kind of material is it gives you a chance to think about, if someone were deciding to survey this or create a rule for that, what might that have meant for them? Why would that be important? Why would they choose, you know, certain rules or choose to collect certain data? So I think that's kind of actually a fun, it's a challenge, but actually can be a fun way to think about these institutions and also see how it changes over time as they start to shift the information they collect. Or, and the other thing aside from patients is the rules around practice, like even beyond kind of the big, like, questions around, say, abortion. You know, it's kind of interesting to see, like, you know, what procedures they thought of that or sort of were good, or what they kind of sniffed at as questionable in terms of what people sought or what clinicians wanted to provide.
Yeah, and especially in the late 19th century, when a lot of these religious hospitals were being founded in the US, they were trying to, as you said in your talk, cater to the quote unquote worthy poor. That is to say, the unworthy poor who are viewed as somehow at fault for their poverty and destitution, those are the folks that were supposed to go to the public hospital, the catch-all institution that received anybody. The people that the religious hospitals and these smaller private hospitals won in the late 19th century were the quote unquote worthy poor. And these rules for admission and discharge were designed to try to screen out the unworthy poor. Let me get to our first question from Arlene McDonald. Great presentation. Could you please return to the divide between a religious objection and a moral conviction and explain? So this may be a call to ask whether this is being distinguished in jurisprudence or in the legal history of these kinds of objections being recognized under the law.
That's right. This is great. And I flagged this when I was talking about the church amendment, because originally, in early drafts, church was like, we'll just like protect the religious beliefs, right? And it's actually, this is one of the connections to my first book, which is that if you read the legislative history and the Senate committee hearings, part of what's happening is someone says, well, wait a second, our draft law has changed over the 1960s through a series of court cases. And whereas the draft had initially only exempted people who had first a connection to a peace church, then a sincere religious objection, but it couldn't be a non-religious objection to war. By the 1960s, the court has tried to create this space for an objection that is moral, but not sociological, political, or philosophical. Now, again, if that is a clear distinction, then you are more precise than, tons of lawyers and draft boards and legislatures, but the court was really trying to find a way to recognize there were people who did not hold to religion either as an organized religion or even over the 1960s to a god or a supreme being, but were making arguments about a moral conviction and an opposition to war. So the language of either a religious belief or moral conviction is imported actually from questions around the draft and the selective service. What is not imported along with that is a system, right? Because part of the way this works with the military is that and again, you can think this was good or bad, but if you were trying to get a religious exemption to military service, you were screened by the local draft board. And this too is a process that changed over time. Originally, to get out of service, you might have gone to jail, you might have paid a fine, you might have had to find a substitute soldier, you might have had to serve in a non-combatant capacity or do other types of civilian public service. So you couldn't just totally get out of the obligation, but you could be in a position where you didn't have to wield a weapon. So we get the mixture of religion and morality from the military, but the statutory foundation of conscience, particularly in the healthcare domain, does not create a system for thinking through this. Jacob Javits, who's the senator from New York, who's a lawyer, is the person who actually, when I said the church amendment is bi-directional in terms of the protection of willing providers along with refusers, that's because of Javits coming in and saying, wait, there could be people who have a religious belief or moral conviction to provide services, and they should be protected too. He also recognized that if you don't create a system, that it's really easy for this to be very blurry, very messy, and for people not to know. He wanted a notification requirement. And that was actually written into the original Senate version of the church amendment. And this is one of the puzzles I'm still trying to figure out. At some point in the reconciliation between the House and Senate, the notification requirement goes away. So.
Great, thank you. And I mean, this question really brings up the issue of whether the kind of moral conviction ultimately becomes a more capacious category as time goes on in jurisprudence connecting religion and state. So for example, and this maybe is a better question for your colleague, Professor Elena Konis, to what degree these kinds of moral convictions have played a role in the modern anti-vaccination movement as much or more than religious objections at the state level, for example, in California?
Oh, absolutely. And you can see in California the way in which there had been a moral exemption that parents could invoke around childhood vaccination. And that actually, the California legislature takes that out, and suddenly the dynamic of vaccination in California shifts dramatically when you no longer can invoke a moral objection. So, I do think, this question of what's a moral conviction or a moral objection and when is it religious, I think you're right that it becomes quite capacious. In the legal domain, part of what, and we're in a moment where things are kind of rapidly changing, the question with regard to hospitals was long framed as an establishment clause issue, but when it comes to personal individual invocations of conscience, it's often as a free exercise issue. And I want to be clear that this can be on both sides of any given medical procedure, of both wanting or refusing it. And if it's religious, it may have more protection, but again, more morality can get you pretty far too.
Thank you. This is really fascinating. This next question is more about having you put your research on religious hospitals and institutional conscience protections, if you will, in the bigger historiography of hospitals. So when I think about the historiography of American hospitals, I think about a lot of the foundational works that were written in the 1980s, 1990s that really focus on this early period that you're looking at in your research, late 19th century to the early 20th. And a lot of that literature focuses on not only the hospital construction boom, but also the shift from lay control and charity-oriented institutions of last resort in the 19th century to, by the 1920s and later, the transformation of hospitals into acute profit-driven surgical care centers for all slices of Americans, especially for paying patients, governed primarily by doctors and then especially later by business administrators. So what for me feels left out of that literature a bit is the religious hospital, because when I read that literature, I think primarily of the gradual disappearance of these smaller hospitals, especially by the 1980s with the period of consolidation and incorporation. So this question is really asking you, I guess, to place your research in the context of these foundational works, these secondary sources written in the 1980s and 1990s, because from my reading anyways, it seems like religious hospitals are adding new dimension to it.
Yeah, and I think religious hospitals kind of complicate the story in a few ways, but also confirm it in others. And one thing that I think is really important and gets back to religious hospitals as corporations is they are functioning as corporate entities. And in many of the major debates, even if we bracket kind of procedures, the major debates around hospitals and healthcare, especially in the 20th century, you get the larger entities, especially the Protestant Hospital Association, the Catholic Hospital Association, the Jewish Hospital Association weighing in. So when it comes to labor issues in the 1930s and whether healthcare workers should be subject to the National Labor Relations Act and time limits on work, the religious hospitals are invested in this, but part of what their argument is our workers are serving because of a religious calling. So of course labor law shouldn't apply. In the 1940s, they argue that similarly tort law shouldn't apply around malpractice suits because hospitals are providing, out of a calling and out of a sense of religious mission, this service. And so, you see questions around, it's actually questions around desegregation that really flag for the lawyers of Catholic hospitals, the looming issues around religion and reproductive healthcare. So I found in the archives letters that they get that where they really are reasoning from race, where they start to see that, as limited as some of the efforts are around construction funds and then later with the Civil Rights Act, the efforts to desegregate hospitals, you get, and it's often nuns who are in Catholic hospitals in the mid 20th century, still often the administrators. They're writing into the lawyers saying, like, we've noticed strings are attached when it comes to race, and the hospital, their views on race tend to depend mostly on location, not so much, right? Like whether culturally in the city in which they exist, it would be acceptable or not. But they write in and say, like, ooh, I don't know, should we take this money? Because what will happen if, and they see these new questions around contraception first, then sterilization, then abortion. is this going to affect us? Are there strings attached? Right? They really anticipate a lot of the issues that arise in the 1970s based on the experience with racial desegregation in the 50s and 60s. And so I think that's really important too, because they see and anticipate the religion issues long before other space policymakers, legislators, judges do. And I think that's actually quite important. I think the other thing in terms of the marketplace is that religious hospitals, again, they're part of these larger associations often. And so some of the consolidation that will happen through contract sales, mergers, acquisitions in the 70s and 80s, it's not that they exist, it's not that on the corporate level, they're part of a larger healthcare institution yet, but they're kind of practicing how do you work out some of these issues, or potentially on a we live in an era of supply chain woes, but how if you have multiple hospitals, Baptist hospitals in a region, could you consolidate your orders, right? I think what's really important here is that religious mission is about sort of what the hospital is doing and also the arguments it will make as it intervenes in these larger public debates. And religious hospitals are kind of, they're doing two things at once. They're both, they're operating in parallel. They are corporate hospitals, figuring out the landscape of professional medicine standards, the market, but they're also figuring out how it interacts with religion and where they want to invoke religion to better position themselves within a marketplace.
That's really interesting. I mean, it definitely seems like the lawyers for religious hospitals are good at arguing out of both sides of their mouth. In one case, they're secular. In the other case, they have religious objections and labor law shouldn't apply, which is fascinating. Our next question comes from Professor Perales, who asks, in your research so far, have you found any key turning points or periods when hospitals articulated stronger arguments to refuse certain procedures based on conscience? I'm curious if it waxes and wanes or if it's more of an upward trajectory, if that makes sense.
Yeah, this is a great question, and it's still something I'm working on tracking. A lot of it does vary by religious denomination, so it's easy, again, to point to the doctrine in the case of Catholic hospitals. The rejection of abortion as a morally illicit procedure is constant in the ethical and religious directives, but questions around how do you handle, for example, ectopic pregnancies do change. Other denominations are different and have different processes for kind of working out. Is something done on a local level? Is there national coordination? But I do think, a lot of the shifts and invocation concepts at both the individual and corporate level, can't be understood without tracking how medicine itself is changing. So there is certainly some anticipation of changes, but it's not until, for example, you get the Harvard Committee on Brain Death articulating a definition of death, and this is an area where Jewish groups and Jewish hospitals differ from many other religious groups. It's the kind of advocacy around an issue, especially when there's something being debated at the state or federal level in terms of law that will, regulate what either is or isn't provided. Usually there are kind of either theologians or interested clergy, operating much before it's a big issue. But hospitals are also trying to figure out what they do and who they serve. And part of what I think is really interesting is it's easy at an institutional or corporate level to paint in broad brushstrokes. This is what Adventist hospitals do. This is what Catholic hospitals do. This is what Jewish hospitals do. This is what Baptist hospitals do. But what's really interesting is if you peer down, what you'll see, and I find this really fascinating, the theologians are often really questioning hospital policies and wondering, especially in a pluralistic environment, what does it mean to serve everyone? So it goes back to this, if your patient population is everyone, and it hinges on serving a diverse population coming in with different beliefs, can you in fact impose your religious views? And this is hotly contested from within. So even though it may look in public, and I think this also gets at interesting questions of, publics. In public, this is what the hospital does. There's often debates happening internally by people who are trained clinicians and trained as ministers or clergy. Where do they see intersections, and where do sometimes they go against their denomination or try to push their group in a different direction? And that varies. Final thing I'll say is just mergers and acquisitions. When you start to see mergers, not just within a certain denominational system, but between religious groups that then need to hash out what it is their new system is providing, what rules they operate by. And this is often very private, very not public, and hard to see. But that's often where there's a lot of kind of questioning over, what care does religion allow or prohibit?
Thank you so much. This has been a fascinating discussion, and we've just scratched the surface, I know. I want to turn it back over to Professor Perales to close out tonight's event. But thank you so much, Professor Stahl, for this engaging discussion.
Thank you.
Yes, thank you so much. I feel like we've learned a lot, and I agree we've only begun to scratch the surface of this wonderful topic. Thank you to Dr. Stahl and to Dr. Schaefer and to all of you for being with us this evening. I'd also like to give a special thanks to our program director, Wes Jackson, and Iggy Harrison and the team at UH Streaming Media for all of their help in producing this event. To learn more about who we are and what we do at the Center for Public History, please visit our website at uh.edu/class/CPH. Once again, thank you for being a part of this event. Good evening and take care. Bye-bye.